We would like to thank everyone for being on our call tonight. We are very excited to bring you two very distinguished speakers with Dr. Thomas Tobin, Professor Faculty, University of Kentucky Gluck Equine Research Center, and Dr. Corey Orava, Chief Science Officer of Enso Discoveries. At first, I'd like to just tell you a little bit about our sponsors. We are MediVet, and our goal is bridging value with innovation. Medical technologies are progressing rapidly every year. Our objective is to deliver these advancements for clinical use in your practice. Our promise is to provide educational resources so you can progress at the same rate. We pride ourselves on discovering and representing the best technologies we can procure for the animal health industry. Our other sponsor, Enso Discoveries, their vision is to offer a wide range of innovative, easy-to-use regenerative medicine kits backed by university science and exceptional laboratory services. And we're very excited to have the NAARV as a co-sponsor. North American Association of Racetrack Veterinarians' mission is to ensure the health and well-being of the racehorse through protecting and improving the veterinary care, treatment, and welfare of the equine athlete, to advance the treatment of disease and injury using evidence-based medicine to relieve animal suffering, and to be proactive in advocating for and administering preventive veterinary care. At this time, I'd like to introduce our first speaker, Dr. Thomas Tobin.
Good evening to everybody, and thank you for inviting me to present. My name is Thomas Tobin. I'm a professor in the Maxwell H. Gluck Equine Research Center, as you can see on the screen in front of you, and I work in the areas of equine pharmacology, therapeutics, and toxicology, with an emphasis on forensic science. Now, next slide, please. In the time that I have been here at the University of Kentucky, equine drug testing is 1 million to 1 billion times more sensitive than when I started. Now, I started in 1975, so it's a little while back. Next slide, please. The take-home messages that I'm going to outline to you tonight are that equine drug testing for what I call a low molecular weight substance, molecular weight less than 500, in the order of 500 or less, those are regular drug molecules, is highly sensitive. We readily detect low picogram. That's a part per trillion level, and that's 1 second in your life when you are 32,000 years old, to put that in perspective. The second point, and this is becoming increasingly important, some administered substances are detected for relatively long periods post-administration. Analysts, regulators may need scientific guidance regarding testing for therapeutic medications, dietary and environmental substances. There comes a point, given the sensitivity of current testing, that you don't need to test down to zero, nominally down to zero. And dietary and environmental substances are increasingly detected, sometimes, as I will show you when we close out, in quite unusual circumstances. Next slide, please. A little history. This is one of my favorite pictures. It was identified by my wife. If you look at the horse on the left-hand side, you'll see that the gentleman is bottling the horse. And if you look at the gentleman in the middle picture in the blue long coat, you'll see that he has a bottle ready to administer something to his horse. And the pictures of this kind would not be unusual in the early 1800s, which is the date on this picture. In other words, it was quite appropriate to administer something to the horse right before post, and nobody got too excited about it. Things were about to change. Next slide, please. And in 1903, the British Jockey Club nominally introduced drug testing. So drug testing for racing horses is the longest established routine drug testing on Earth. It's the broadest in scope. We nominally test for basically everything. There are a few limits on the sensitivity of testing, although the limits are increasing and have been increasing during my career here. It can be a very stringent regulatory context. You detect the molecule, no quantitation required, and you're facing a penalty. Apparently, and I understand this from my legal colleagues, and I am no lawyer, a number of U.S. constitutional protections are not functioning on the racetrack for a variety of reasons. And medication can apparently, presumably, influence performance, although the hard science that they do that is sketchy at best. Next slide, please. The reason I'm here today talking to you is that in 1968, a horse called Dancer's Image, number 9 there on the right, was the first past the winning post in the Kentucky Derby. It wasn't the first past the chemist. There was a positive for phenylbutazone called, and it was argued over in the courts for quite a number of years, and led to the creation of the Kentucky Equine Drug Research Program. And I came to Kentucky in 1975 to get that rolling, and with all due respects, I've been there since. Next slide, please. One of the first things I did when I came to Kentucky, I came in 75, and in 1980, I published a book called Drugs and the Performance Horse. If I was writing it again today, I wouldn't have the word drugs in there because the word has so many negative connotations now that weren't obvious to me in the 1970s. His Highness, Prince Philip, the Duke of Edinburgh, wrote the foreword for me, and he wrote a very good foreword. The dividing line between the treatment of injury and disease on the one hand and the preparation of horses for competition on the other is very narrow and not easily defined. And that's what we've been working on for the last 45 years, is defining that line in quantitative terms. And I'm going to tell you how we do it. And I'm also going to indicate the, the difficulties with any approach to the problem. Next slide, please. Next question you might ask, who actually gets a positive? And the answer is, if you race a horse, you are at risk. And this is Her Majesty the Queen. One of her horses failed a test on February 19, 2009 for tranexamic acid. That was probably they miscalculated the detection time, withdrawal time. And there was another incident after that where a trace of morphine, an environmental trace of morphine, was identified in a horse belonging to Her Majesty. So anybody, no matter what you rank and how clean and careful you are, you're at risk. That's number one. Next slide, please. This is the technology when I came to Kentucky in 78. It's called thin layer chromatography. And this is a glass plate about the size of a page on a book. And it's covered with a thin layer of silica gel. And if you look on the right-hand panel, halfway down in the middle, you'll see Lasix and you'll see a spot. And what happened there was the extract was put on the plate, spotted on the plate about where the L is on Lasix. And then the chromatography solution was allowed to run up the plate. And what it does is it picks up the drugs and it carries each one a slightly different distance up the plate. And then you dry off the plate and you spray it with a coloring reagent that the medication reacts with. And bingo, your spot for Lasix comes up about 40% of the way down the plate from the start on the far right. And that's the chromatography, which is the movement along the surface, and then you have the identification of the mass. It was very adaptable, it was inexpensive, it was not particularly sensitive. We're talking about micrograms per ml. One of my early contributions in the 80s, ELISA tested for racing, and we increased the sensitivity in the order of 1,000-fold in a relatively short period of time. It was an interesting period in my life. Now, you see that spot there. There's two things we know about it. We know that it has migrated a certain distance, and we also know that it has reacted with a certain color, but that's all we know. Now, suppose we were able to accurately measure to 3 decimal places the mass of that molecule, That would be very helpful, because if you know the mass of a molecule to 3 or 4 decimal places, that makes certain candidates highly likely. And let's suppose we could then also take that molecule of X molecular weight and break it up into fragments. And if it broke up in a specific fragment pattern consistent with that molecule, you'd have extremely good evidence that that was the substance in question. And that is the way drug testing is done today. Next slide, please. It's a little more complicated than the thin layer system I've just shown you. This is a liquid chromatograph, mass spectrometer. And the lady is sitting in front of the liquid chromatograph, which does the chromatographic separation step that we just saw on the thin layer plate. And then the sample at a certain, that's coming off at a certain point from the chromatograph is, first of all, the mass of the molecule is detected. And I'm going to show you methylcarbamol. And the mass of methylcarbamol is 241.2405. That's the parent drug. And then the molecule, the 241 molecule, is put into a fragmentation chamber, and the drug is fragmented. And it fragments in a specific pattern. And if you find the fragments and the parent drug, and we'll show you this, this is an extremely sensitive and specific detection methodology. And I remember when we first introduced this in the late 90s, I was extremely impressed compared to what I'd seen when I started in equine drug testing. Next slide, please. Just a scheme. You have the MS1 is the first mass that comes off. Then you put them into the green, the fragmentation chamber. You fragment the mass, and you get the product ions, the second group of products, and the whole thing is related together, and it has the standard chromatography time. Next slide, please. Here is the mass of the methylcarbamol. It's 241.241, and the structure. And now we're going to look at the chromatographic products, and everything starts. Next slide, please. Here we have each of these peaks is, the top peak is the parent drug itself. It's methylcarbamol, and it's got the 242.1. It's picked up an extra mass unit because it's become charged. And the retention time on the column is 3 minutes, and you can see that on the bottom axis. And all of the fragments are coming off at the same time on the column. And we have methylcarbamol breaking down from 242.1 to 163. That's the second peak we see. To 199 is the third peak. To 118 is the fourth peak. And to 203 is the fifth peak. So you have the parent and 4 fragments. That is extremely good evidence as to the specific identity of this material. And when you can identify that specifically, you can become very sensitive. So how sensitive is this testing? The microgram per ml that I showed you with the thin layer is 1 second in your life when you were 85 hours old. The nanogram, a part per billion, is 1 second in your life when you're 32 years of age. That's where we went with ELISA testing. The picogram is 1 second in your life when you're 32,000 years of age. The femtogram is 1 second in your life when you are 32 million years old. And we're well into the picograms and the very occasional femtogram. That's where we are. And if you go down another 1,000, we have an attogram, and another 1,000, a zeptogram. And that's 1 second in your life when you're 32 trillion years old. And that's also equivalent to about 2 molecules, approximately, of phenylbutazone. So an attogram is 2,000 molecules, a femtogram is 2 million molecules, and a picogram is 2 billion molecules. So the numbers are quite, it's a numbers game, and they're not numbers that we're used to routinely in regular life. Next slide, please. So the next question then is, how long can a drug administration be detected? And the detection time depends, and this is the way I approach it, on three things. The first thing I'll always ask when I'm asked about a drug in a horse, I'll ask for the dose, because the dose gives you an estimate of the number of molecules administered. And if it's a real high dose, 10 to the 22 molecules, which by the way is more molecules than there are stars in about the number of stars in the known universe, that's the number of molecules you're putting in. And if you're using an extremely potent drug, torphin was one, it's about 10 followed by 60 zeros. So there's a 100,000 fold range in the dose of the drug put in. And if you put a high one in, the chemist is simply going to trip over it, end of story. And it may wind up in the barn and the stall and give rise to environmental contamination. That's out there at on those high doses. The second thing is, and I'm going to show you this in a little more detail, the terminal plasma half-life of the substance. And that can range from in the order of an hour or two, a couple of hours, to actually, I believe, to years. Though those have been showing up recently. The third factor is the sensitivity of the testing system, which, as I have just shown you, has increased approximately a billion-fold over my career in this field. So number of molecules, half-life, and sensitivity of the testing. Now let's look at a number, a slide on, next slide please. The number of drug molecules per dose. Naproxen, 8 grams, is about 2 times 10 to the 22 molecules. Like I said, equivalent, approximately the number of stars in the known universe. Phenylbutazone, about 10-fold less. Amphetamine, 6 by 10 to the 20, 150 milligrams. Morphine, 9 by 10 to the 19 molecules. Fentanyl, which when I started this business was undetectable, 2 times 10 to the 18 molecules. And atorphin, which triggered the introduction of ELISA testing into racing, 6 times 10 to the 16. So 100,000-fold difference between 10 to the 16 and 10 to the 22 between the atorphin and the naproxen. This slide is phenylbutazone, and I've got 6. If you look at the zeros, you've got 3, 6, 9, 12, 15, 18, 21. That's 6 times 10 to the 21 molecules. That's what you inject to the horse when you inject 3 grams intravenously. And I have set the half-life, the terminal half-life, at 7.22 hours. And the reason I set it at 7.22 hours, which is just a little on the long side for phenylbutazone, is that half of it is gone, half of what's in the horse is gone at 7.2 hours. Another half of what remains is gone at 14 hours, and another half is gone at 24 hours, 7.2. So what happens is, if you've got a 7.2 half-life, a 0 drops off the end every 24 hours. And that's what happens. That's how horses administer, and you and I eliminate drugs. A 7.2 hour half-life, the first 0 is gone. I've got that as 1. And the pharmacology will be more or less gone. It will certainly be gone by the time you've got 2 zeros, which would be 99% of the dose administered. But you still have an enormous number of molecules left in the horse. And the question then becomes, where should we tell the chemist to stop testing? Because although the drug is detectable, it's not going to produce any effect. It's simply background noise. And the other thing is that in this particular case, it takes 63 half-lives to completely eliminate the drug. And bute is a high-dose drug, so my rule of thumb is 60 half-lives to completely eliminate the drug from a horse. Those are some simple mathematics and a simple demonstration of the way we get rid of medications. Next slide, please. How long will a drug remain detectable? If you really want to go after phenylbutazone, you could probably find it for 15 days with current technology. And that's just my best guess. Methylprednisolone, the withdrawal time after intra-articular administration of 100 milligrams, which is not a big dose, is minimum 21 days. And that's presuming it went in intra-articularly. And if you miss the joint and go into a muscle, the half-life is much prolonged and the detection time is much prolonged. Boldenone, given as the decanoate as an oily preparation intramuscularly, you give 450 milligrams subcutaneously. You can detect it out for 150 days. I'm going to show you the data on that. Medroxyprogesterone, 500 milligrams in humans. A single dose, 500 milligrams, has been detected for 9 months in plasma. And telluronic acid, just been published, 500 milligrams intravenously, still detected 3 years after the last dose. So, like I said, you watch the amount of medication you put into the horse is one thing. And the second thing you look for is the half-life. And the half-lives can be highly variable. Next slide, please. This is the telluronic acid data just published, Riggs et al. And we've got nanograms, it's 500 milligrams administered intravenously. And you can see out here at 1 year, 2 years, and 3 years, you can see between 2 years and 3 years, the plasma concentrations of the drug are not declining. They're in the order of 200 picograms per ml and pretty steady. And they didn't even estimate a terminal half-life, but it's obviously very long. And I would estimate in the area of years. And that has just been published and is, to my knowledge, the longest half-life, terminal half-life ever reported. Now, telluronic acid is an unusual medication, but those are the facts. Next slide, please. This is medroxyprogesterone. This one has come up recently, and you can see this is an intramuscular administration of only 150 milligrams. Is subcutaneous. And apparently it's characteristic of this product that it very slowly releases the substance. So the rate at which it is released into the blood is what controls the apparent terminal half-life. And I should make it clear that this is not the true half-life. The drug is being released slowly into the blood, and this one has been reported detected for 8 months after a subcutaneous administration of 150 milligrams. Next slide, please. This is an RMTC, Racing Medication Testing Consortium experiment with boldenone, probably done, I shouldn't be able to remember when it was done. It's at least 10 years since. And it's administered subcutaneously, I believe, single therapeutic administration, a 450 milligram dose, which is about the same as the telluronic acid. It's given as a decanoate precursor in oil, and it's slowly released. And you can see that this again is released. The terminal half-life is about 15 days, and it drops off the chart. The limit of detection is about 25 picograms per ml. It begins to drop off the chart between 100 and 150 days after administration. Very long plasma half-life, and the second thing is you have variability in the rate of elimination, and that determines when the animal goes clear, the detection time. Next slide, please. The plasma half-life, the parameters, this is from Pierre-Louis Toutain, who is a veterinarian and a mathematician and a pharmacokineticist. The parameters that have the greatest influence on the value of a DT, which is a detection time, are those that control the terminal half-life of the drug distribution. In other words, it's the biological variability in the terminal determined by the horse. He's thinking about one particular drug and administered to a large number of horses, and you're going to have horse-to-horse variability. It can be quite substantial, and his conclusion is, in practice, this means that the main sources of uncertainty on a detection time are of biological origin and cannot be reduced by any managerial options. In other words, it's something, the variability is something you have to live with and include in your calculations. Next slide, please. I'm going to close up shortly, but I've told you about the terminal half-life and the problem with detection times. I'm going to tell you now about a little trick of Mother Nature. And there are quite a number of these. Aminorex is an amphetamine-related stimulant, and you may recall that it's found in the horse as a metabolite of levamisole. This was figured out about 10 years ago as an immune stimulant, and that changed the status of levamisole as a therapeutic medication because it was giving rise to Aminorex. More recently, we've discovered that this substance can also appear in horse urine if the horse is eating a Kentucky pasture weed, yellow rocket, which contains berberine, which is structurally related to Aminorex, and we believe is the source of the Aminorex. And we just reported on that about a year ago. Next slide, please. So the take-home messages are equine drug testing for small molecular weight molecules, 500 or less, is now highly sensitive and specific. We readily get down to part per trillion levels, which is 1 second in your life when you're 32,000 years old. Administered substances can, depending on the terminal half-life, be detected for relatively long periods post-administration. Analysts may need scientific guidance as to when to, quote, stop testing for therapeutic medications, dietary and environmental substances. And as we have explored this supersensitive testing, we find traces of dietary and environmental substances. The Queen's morphine was a dietary contaminant in the feed, and environmental substances and Kentucky yellow rocket berberine. These things are being increasingly detected, usually in specific circumstances and at times in specific locations around the world. I thank you very much for your attention. Let me have next slide, please. I've been supported over the years by the Kentucky Horse Racing Commission, the Kentucky Equine Drug Research Council for the early part of my career, and more recently by the Horsemen's Benevolent Protective Association. And I've listed there the groups that have supported my research across the country, and the continuous support of the University of Kentucky and the director and faculty of the Equine Gluck Equine Research Center and the University of Kentucky Equine Research Foundation are gratefully acknowledged. I thank you very much. I'll stay with you. I'd be happy to answer any questions.
Thank you so much, Dr. Tobin. And did you want to speak on your most recent book?
Just a few words. This is actually just before the RMGC started, before we began the National Uniform Medication Rule, and it's basically an outline of all the drug testing thresholds that were in place across the world, actually. And we are progressing slowly in the direction of standardized testing, and that's the state of the art in 2012. And as we speak, we're working on another one. Okay, and thank you very much indeed.
Thank you.
Excellent. Okay, I've got a lot of information to get through, and I realize people are giving us time of their evening, so I'm going to get right into it so we can have room for questions. I'm going to go first through some musculoskeletal injuries common in the thoroughbred racehorse. Then I'm going to talk about how wounds heal and why platelets, and specifically the growth factors found within them, are important. We're really going to go in depth with the in vivo PRP literature. And the reason I say in vivo is because there's a lot of in vitro stuff, but it's so tough to extrapolate some of it. I'm then going to go to questions I commonly get asked. For example, can I freeze PRP? Should there be white cells? How many platelets should there be? And what other modalities, such as shockwave, can I use with PRP? Then lastly, we'll bring up some regulatory issues regarding platelet-rich plasma. All right, so first, disclaimer, I am not a racetrack vet. I'm an equine vet, but my background is mostly English sport horses. I've been in industry now for over a decade, exclusively in regenerative medicine. So you guys are definitely more familiar with the injuries with race horses, but this is a series of papers. They actually published 3 papers recently. They're out of Australia, 2 at the end of 2020 and 1 in 2021. So I figure you guys might not be familiar with them. What they did is they were looking at Australian thoroughbreds, basically followed them for a year. They were looking for how many horses were in training. They broke them down either as 2-year-olds or older than 2-year-olds. They were looking for how many musculoskeletal injuries occurred, what type of injury occurred, and whether the horse basically raced after injury. And their definition was if they didn't race within a year, then they didn't race. And then lastly, they looked at fatalities. So what they found, obviously week to week, the number of horses vary. On average, it was 544 horses. Approximately a quarter of them were 2-year-olds, so obviously 3/4 were older. They found the incidence to be quite low, 0.6%. So the 2 numbers beside it, the 195, that was 195 horses, 202 injuries. So obviously a few horses had more than 1 injury. These were evenly split between the 2-year-olds and the older horses. But if you remember, the 2-year-olds were only a quarter of the population. So the 2-year-olds were more likely to get injured. The most common injury among 2-year-olds was dorsal metacarpal disease. In older 2-year-olds, there was more diseases commonly affected. So suspensory desmitis, flexor tendonitis, sesamoid bone fractures, as well as injuries to the fetlock joint. So of the 195 horses that got an injury, 82 of them did not return to racing, and that was 42%. And this is split actually identically to how they represented the population. So even though 2-year-olds were more likely to get injured, they weren't more likely to not return to racing. Okay, continuing. They looked and found summertime, horses were 3 times more likely to get injured, but that was only for the 2-year-old population. And you think about it, it kind of makes sense because they haven't been around as long, so they're not as skeletal mature. Also note, summer in Australia is right now, but they give their birth date as August 1st. Other studies have shown track conditions can have an effect. They did not find that. Of the 14 fatalities, 2 were accidental, so that left 12 due to musculoskeletal injury. And they make us think a really good point. They say that a lot of the literature talks of fatalities at the track, and they said 9 of the 12 were actually in the training arena, so fatalities may be severely underrepresented. Of the fatalities, in the 2-year-olds, most common was a humeral fracture, and in the older horses, the sesamoid fracture is most common. This is a table from the book, and if you can notice the first line, dorsal metacarpal, see how the text is bold and the next line is not bold? A bold line just means it was statistically significant. So if we look at the first column with the numbers, 5 out of 47 horses, that's 11%, did not return to racing of horses with dorsal metacarpal disease. We looked at the next chart, now we see 42 of 49, so that's 89%. So going through the ones that are statistically significant, so horses with dorsal metacarpal disease are statistically more likely to race again. If we look at suspensory, check ligament, sesamoiditis, they are more likely to not race again. If we look at SDF tendonitis, more likely to not race again. We're going to skip past the injuries because that's basically bad luck happening. The proximal sesamoid bone fractures, splint bone fractures, and sesamoiditis, again, significantly more likely not to race again. Okay, so let's go on to PRP. So why do we care about PRP? What makes platelets so special? And it comes down to growth factors. And I know when I was in practice, when I saw acronyms pop up like this, my eyes would glaze over. So I'm not going to go into much detail about them. In simplest terms, a growth factor is a chemical produced by one cell that can tell another cell what to do. Now, there's lots of chemicals in the body that can do that. Cytokines, for example, interleukin 1, interleukin 6. But there's a difference. Some cytokines can be pro-inflammatory. Some cytokines can be anti-inflammatory. When it comes to growth factors, there's no such thing as a bad growth factor. It's kind of in their name. They promote growth of cells, proliferation of cells, and differentiation of cells. Now, you can have too many growth factors, but in general, there's no such thing as a bad growth factor. There's also good things in plasma that have been shown to accelerate wound healing. So why is this exciting? Well, first of all, you can't get these, meaning there's no bottle on the shelf that you can order for these growth factors, especially equine. Some of them you can buy human, but there's a couple issues with that. One, they're ungodly expensive. One dose, and we don't even know if it would be a therapeutic dose, it's going to cost you hundreds, if not thousands of dollars. Second, they're typically recombinant human, so now you worry about a reaction. And third is growth factors tend to not work very well on their own. It's kind of like, if you look at Merck's handbook or Plum's handbook for aspirin, in vitro, aspirin is the second coming. It can do so many things, but in vivo, aspirin is meh. Growth factors that way too. In vitro studies, some of these growth factors can do phenomenal things, but you use them individually and they tend to be underwhelming. One of the reasons for that is growth factors tend to work with one another. So growth factor A can influence growth factor B, which can influence growth factor C, which can then in turn go back and influence growth factor A. So it's kind of like a spider webbing. So that's what's really exciting about platelets, is that platelets have all the growth factors in them, and presumably in concentrations that are there for a reason, and we're going to get to that reason in a second. We should all be familiar with the various phases of wound healing, and we know it can be complicated because you can have an old injury that is re-injured, so now everything can be going on in one wound. The whole purpose of this is just to say, all right, when do I treat? Early, late? It's kind of a trick question. Growth factors influence every phase of healing. So there is no wrong answer. In general, I like to treat as early as possible, with the one exception. If I had a tendonitis that occurred today, I'm likely going to rest it, ice it, get the heat out of it for maybe 5 days before I consider treating. But I'm not going to wait 5 weeks. I'm definitely not going to wait 5 months. All right, going back in time a bit. I was in vet school in the 90s. The only concern with platelets was thrombocytopenia, because then I'm worried about a bleeding disorder. So platelets move along the endothelium, minding their own business. But when we get a break in the endothelial wall, as represented in the top, different things are exposed. Collagen, von Willebrand factor, tissue factor. These are things that platelets recognize. And when they do, they become activated. And they'll actually change shape. They'll become like an octopus. They'll put up projections that can trap other platelets. When that does, that forms your primary clot, so we don't bleed to death. Okay, but why all the growth factors? Well, think about it. The blood vessels usually just spontaneously rupture. And obviously the answer is no. There's probably some damage to the tissue up here. It doesn't matter if that was a liver or a tendon. Some damage happened up here. Okay. How does tissues heal? We just went over that. They need growth factors. So now it's kind of intuitive why platelets are chock full of growth factors, because they're the first cell type to show up that injured area. They're going to stick to the area. They're going to degranulate. They're going to release the growth factors, and they'll dissolve into the local environment to coordinate healing. The body is really good at fixing little problems. The whole idea behind regenerative medicine, these orthobiologics, is, okay, can we take something from the body that's not going to be missed? In this case, blood. Let's concentrate the platelets, therefore we can concentrate the growth factors. And now we reintroduce them to a part of the body that's exceeded its capacity to heal. All right, how do we make PRP? It starts with centrifugation. The way centrifugation works is that the components of blood have slightly different densities. Red cells are the heaviest, so they go down to the bottom. A couple things to notice. Notice that platelets and white blood cells have a little bit of overlap. So even though you can make leukopoor PRP, there's always going to be some white cells in there. The other thing is, you notice the white cell has a pretty big range for their densities. The reason for that is neutrophils have a slightly different density than, say, lymphocytes or monocytes. It happens to be in a good way, in that neutrophils tend to be heavier, so they are further down the column. So when you do a differential of PRP, you'll have relatively less neutrophils than you would in whole blood. When you're centrifuging, it's important, and this comes into medical device manufacturers, when you're doing validations, you need to first of all centrifuge it hard enough to separate the blood, and that way you have a decent volume of plasma to work with.
Luckily, it's.
But you don't want to spin it so hard, because if you spin it too hard, you're then going to push your platelets down. Ideally, the bottom half of your PRP should be platelet rich, and the top half is going to be platelet poor. Although even in some cases, even the top can be platelet rich. If you're using a centrifuge, and this tends to be the bigger digital centrifuges, they may have a brake option. It's also important to turn off the brake, because the brake is just like the brakes in your car. If you slam the brakes, you get thrown into your seatbelt. If you have a brake on in a centrifuge and you pull your PRP out, you're not going to have a nice clean demarcation from red to yellow like we see here. Instead, this hole here is going to be rather nebulous and blurry because of that sharp deceleration. You do not need an anticoagulant to make PRP, but if you don't, you need to be very careful. You need a clean stick and you need to work quickly. Otherwise, the blood can clot on you. I personally always use an anticoagulant. We include it in our kit. If you're doing PRP, it needs to be a citrate-based anticoagulant. So you've got 3 options: sodium citrate, ACD, or CPD. You can't use EDTA, you can't use heparin. All right, equine vets, most are familiar with PRP, but most don't realize just how much literature there is out there. You go to the NIH and search platelet-rich plasma, and that's in quotes, so I'm looking for that exact phrase. There's over 11,000 hits. Now, to give you an idea, Equine, which has been around for 20 odd years, has barely 500 hits. And I'm not taking anything away from Equine, I'm just showing how much more PRP can do. Human side, get a lot of interest, typically from elite athletes. The first publication, though, was at the University of Miami over 20 years ago. They were looking at fixing injuries within the mandible. They then got into dermatology conditions, and then more recently, orthopedics. More recently still, they've gotten into things like reproduction and even ophthalmology. So there's a lot of data, but how do you know it's good data? And this is where evidence-based medicine comes into play. And evidence-based medicine says not all studies are created equal, and they typically use a pyramid to represent this. The higher up the pyramid, the more we believe the study. When I was in vet school, the king of the crowd was the randomized control trial. But if you look at most of these, the randomized control trial isn't the top of it. This one is actually fourth from the top. Almost always, the best studies are meta-analyses and systematic reviews. So these are papers that actually do not enroll patients. Instead, they pose a question, such as, does PRP work in humans for knee arthritis? Then they'll go through the literature and find studies that meet the criteria. And their criteria, they may only look at randomized control trials, but then they'll combine them into one big study. Well, guess what? There is a meta-analysis using PRP in people for knee arthritis. These are academics, no conflict of interest. They only looked at randomized control trials. Combined, that's over 1,400 patients. And the controls range from hyaluronic acid to corticosteroids. And what did they find? Not only did PRP work, it works better. So the best evidence out there says PRP works better than steroids for joints. And in humans, they're showing at least up to 12 months. But that's not the only meta-analysis. There's also this one, and this one, and this one, and this one. And I think you get the idea. There is an overwhelming body of information supporting that PRP works. And these are orthopedic conditions. The two conditions with the most evidence are knee arthritis and tennis elbow. So how do you make sense of it? Well, these guys actually did a summary of meta-analysis, which I didn't even know was a thing. And what did they find? PRP is more effective for pain and function in terms of knee arthritis. And also important, it's no increased risk than other treatments. Okay, on the equine side, we obviously know there's a big push getting away from steroids, but it also is on the human side as well. This is a recent publication where academics from the US and Europe reviewed some of the common findings that are associated with intra-articular corticosteroids. They broke it down into 4 types, and I'm not going to go into them in detail. Their conclusions were, though, if you have a patient where radiographically you either don't have signs of arthritis or just mild signs, you should really scrutinize your rationale for doing corticosteroids. And the reason is you presumably have a healthy joint. Now, yes, you can have a relatively minor changes and still have terrible cartilage, but in general, tends to be a correlation. So you have a potential to do a lot of harm to that joint. If it's an end-stage joint, we already knew it was end-stage joint, so there's less kind of in play. The other thing they said is if you are treating these mild cases, before you give them subsequent injections, assuming they need serial treatments, repeat radiographs, just to make sure you're not doing one of these 4 things. There are times when I use steroids, and I'll recommend them steroids, and I think this paper summarizes when I will make that recommendation to somebody. So this is a randomized control trial in humans, equally split between, there was 46 patients. In order to get into it, they had to have failed conservative treatment, so that's physical therapy as well as oral drugs, and they had to respond to diagnostic anesthesia. So they put, I can't remember, lidocaine or something into the facet joints. Randomly treated with either PRP or betamethasone with lidocaine. Fluoroscopic injections. And the one thing I thought when I first started this study was lumbar facet joint in the human can't really be that big. So they put in 0.5 mils, and I was concerned, is that enough PRP to actually get therapeutic effect? And they were followed for 6 months. Okay, so this is a study, this is the results. This is a functional index. So the lower the score, the better. So these people start up here, and this is, we're only looking at steroids right now. So at 1 month, kind of what you expect, steroids are potent anti-inflammatories. So these people are significantly better function at 1 month. But kind of like we know with steroids is that effect wears off. PRP has a completely different curve. And when I put the trend lines on it, it's even more obvious. So going back to my initial thing, when I'm going to recommend to my client, now again, I'm in the English sport horse world more so than the track. So if I've got a client that the next 2 weeks are more important than the next 2 years, that's where I say steroids, because I know how potent they are. I know what kind of response I'm going to get. PRP, you will get patients with PRP that respond within a few days, but it tends to be a slower onset. Okay. The other thing too, this is a good point too. We all know there's nothing that works 100% of the time. So I think this one is pretty representative of my experience with PRP as well. So this is 6 months. So this is the PRP group. 52% had excellent outcomes, 29% good. But then 10 of them had fair and 10 of them considered poor outcomes. So you can still, it doesn't always work. So that's about 80% and about 20%, but compared to steroids where it was 50-50. So their conclusion, PRP is the superior treatment for longer duration efficacy. All right, let's get into horses now. So the first publication in horses almost 20 years ago. So this was for wound healing. What they did is they surgically created an injury below the carpus. They made PRP and then they activated it. So they let it turn into a gel and then they applied the gel to the wound. The reason for the gel is so that the stuff would stick around. Sure enough, they saw accelerated epithelial differentiation as well as better collagen. I know the Racetrack, not doing a lot of breeding, but some of you are going to be working at farms as well. So I'm going to cover theory, but I'm literally going to just knock it down to one slide, even though there's a lot of literature out there. So PRP has been used in the testes, not in the horse. This has only been on lab animals so far. So direct injection into the testicle and multiple studies showing improved spermatogenesis as well as testosterone production. Similarly, studies have done intra-ovarian injection. So these ones, they've done it in the cow. And so in the cow, they were doing it in normal cows, but trying to increase their superovulation for embryo transfer. And so one injection, they were able to more than double the amount of viable blastocysts they could receive. Similar to the other study, which was done actually out of Cornell, was a pilot study in women. And they had women who had basically ovaries that had shut down on average for 5 years. And they got every woman in the trial who had this is a transvaginal injection into the ovaries. Every one of them was able to produce a viable blastocyst. In the horse, the only work that's been done with PRP for Therio is intrauterine. And there's quite a few places that have done it, and they've actually all had very similar results. They've shown that you can take a pro-inflammatory uterus. So typically what happens is these are mares where the uterus responds to either the semen or some extenders in the semen and creates an inflammatory environment. So by the time that fertilized egg comes down the tube, there's inflammation in the uterus. It's not conducive to implantation. You don't conceive. So they showed that you can take a pro-inflammatory uterus and get rid of that inflammation. You can reduce fluid retention, and in some cases, you can more than triple the conception rate with one infusion of PRP. Okay, now let's get on to musculoskeletal conditions. There's a ton out there for bench work. At least 40 has probably done more than anybody. I'm not going to go into them. I just want to make you aware that there are a bunch out there. We literally just don't have time to get into it. So we're going to focus more on in vivo stuff. I love science. I'm on PubMed virtually every day looking at papers. This paper now, I think it's almost about 10 years old, out of Utrecht in the Netherlands, is a beautiful study. It's really well done, but there's one limitation. And that limitation was it was a surgically created lesion. And we all know surgically created lesions aren't the same as naturally occurring tendinitis. They're nice because at least they're consistent between lesions, but it's the one limitation. Otherwise, this is a fantastic study. So 7 days afterwards, they were treated with PRP or saline, followed out for 6 months. And what they found was PRP-treated tendons had better organization of the collagen network as well as improved metabolic activity. So a single injection can influence repair of surgically created lesions. This is a study of Europe where they actually looked at racehorses. So this was 22 racing thoroughbreds with naturally occurring tendinitis. They reported positive influence in healing, getting more horses back to racing, and shorten rehab time. The problem was this wasn't a controlled trial. So they were using historical data to compare to the other ones. But without controls, you don't know, okay, in the rehab program, did they something new involved? So it's promising data, but it's not the best data. There is a study with tendons that is controlled. So this one is out of Germany, 20 horses, 10 got PRP, 10 got saline, 1 injection of 3 mils. Here's the issue though. Even though it's naturally occurring tendinitis, none of them were racehorses. They were different breeds, different uses. Like one was a police horse, and a lot of them were dressage horses. And so what ends up happening, you end up, first of all, they're not putting the same strain on it as a racehorse. They tend to be much older horses, but it's also they tend to get more marginal lesions or diffuse lesions opposed to core lesions. Still, at least we've got data showing that 80% of them were able to come back to full work, and the control group was only 50%. So my takeaway when it comes to tendons is, does PRP help? Yes, I truly believe PRP helps with tendon injuries. Is it a magic bullet? No, not even close to a magic bullet, but it helps us. It's one thing in our favor to helping them. They also need a good rehab program. They need rechecks, and that rechecks, I believe, in serial ultrasonography as well. Okay, we're going to switch to joints. When it comes to joints, if you inject anything into a joint, you should be confident that it's safe. Well, there's actually a published safety study. These are Brazilian academics published in the Canadian Vet Journal. They had 8 horses, and they were looking at putting PRP into the fetlock joint. And there was 2 protocols to the study. The first protocol was 1 injection of either PRP or saline. The other protocol was 3 injections a week apart. What they found was, in the short term, there was a transient increase in white blood cells. Now, at first you're like, oh, PRP creates inflammation. If you read the paper, even the saline group had increased in white blood cells. And then when you read the methods, the PRP they used happened to have leukocytes. And the authors even admit, did the PRP group create inflammation, or did they literally just introduce it? But it's kind of a moot point, because in the long term, which is really what we care about, there was no difference. So their conclusion, PRP is a safe option for intrasynovial administration. All right, now we can get on to clinical trials. Similar to what we saw with tendons, the first pilot studies came out, and they weren't controlled studies. So this one's out of Europe, 20 horses. And I don't know about you guys in the racehorse industry, but in English sport horse, if I had a horse with a fetlock that was refractory to corticosteroids, I'm not thinking good thoughts. These are tough horses. You're now kind of behind the curve. They got 80% of those horses back into work at 12 months. But again, without a control population, you're like, okay, it could have been done to something else. Well, there is a control trial, again, out of Europe. So this is 15 horses. Again, I think this is a tough population of horses to deal with. Now we've got moderate to severe degenerative joint disease of the coffin joint. This is 3 mils injected, and it's frustrating sometimes in the literature. So many studies don't tell you what platelet concentration to use or if the leukocyte concentration. This one happened to, so it was just a moderate concentration of platelets, 2.5x, and leukodepleted. They did a second injection about 3 weeks later. I don't plan to do second injections. I'll let my recheck determine if I can do second injection. But what did they find? First of all, no adverse events. And another thing too is virtually every paper I'm going to refer tonight, I've put in a Google Drive folder. Some of those papers I don't have full rights to, so I can't e-blast it, but I'm happy to email individually. So at the end is my email address. If somebody wants it, I'll send you a link to that folder. Every study I'm going to show, there's no serious adverse events associated with the PRP therapy. So in this group, and again, they got 90% of those horses back in full work at 6 months. Now, they weren't all sound. 2 of them still had some lameness, but they were sound enough to be back in full work. But more importantly, none of the control group had reduced lameness. So now we have much more confidence that that treatment response was actually due to the treatment and not a placebo. One of the questions I get asked a lot is, did they get better on x-ray? And I have never seen a horse get better on x-ray after PRP. What this one has shown was that in the 6 months of the study, they didn't get any worse. And I think that's kind of the best thing we can hope for is, can we maintain them longer? So hopefully we never get to that end stage joint. Lastly, when I first saw this, I was like, well, that kind of sucks. I got lame again. But then I thought about it. These were horses with moderate to severe arthritis of the coffin joint. Hard cases to deal with. So potentially you could manage them with twice-a-year treatments. If that was the case, I would consider that a win in my books. Okay, just like I said, you should be confident that when you inject a joint, it's safe. But personally, if I understand what's happening in the joint with the drug, I'm much more likely to recommend it to my client. I have more faith in it. So it's a great review article out of Brazil. It's a few years old now, so there's been new changes to it, but this still kind of summarizes most of it. So they break it down into 4 categories. And the first is hyaluronic acid. We all know what hyaluronic acid is. We do it for viscous supplementation. You know the axiom, give a man a fish, feed him for a day. Teach a man to fish, feed him for life. This is a good example for that. The growth factors in PRP can stimulate synoviocytes as well as chondrocytes to actually produce HA. So injecting HA is kind of like giving a man a fish. Injecting PRP is kind of like teaching that joint to fish. It's making its own. There's also data showing this occurs in the horse as well. So this, we're not necessarily extrapolating from other species. There's also data showing that in PRP is another product called surface zone protein. And surface zone protein is one of those chemicals that really reduces viscosity. So PRP itself can actually be viscosupplementation. And that may be why some of these patients can be significantly better within hours of injection. There's evidence that growth factors can also help regenerate connective tissues. But in my experience, and talking to other people that are in the field, we think the most potent result of PRP, the most potent effect is anti-inflammatory. And this is obviously a pretty complicated chart, so I'm going to break it down step by step. So we have a chondrocyte and we have a bad guy. I think most of us have heard of IRAP. Well, that becomes because of this bad guy, interleukin-1. It is a pro-inflammatory cytokine. So in arthritis, what's going to happen is it's going to bind to its receptor, it's going to start a signaling cascade, and you're going to get production of what's called matrix metalloproteases, MMPs. An example of these is like collagenase. These are bad news. These break down connective tissue. So how does PRP work? Well, we've all heard of IRAP. IRAP stands for interleukin-1 receptor antagonist protein. That protein is found in PRP. And so what it does is it binds to the receptor. So now interleukin-1 can't get to its receptor. So this pathway doesn't get turned on and you don't get production of the MMPs. Well, IL-1 is not the only bad guy in arthritis. There's also TNF-alpha. And TNF-alpha kind of works the same way. It binds to its receptor, turns on a cascade, produces MMPs. And just like PRP contains interleukin-1 receptor antagonist, it also contains TNF-alpha soluble receptor. So now this, instead of binding to the receptor, it actually binds to TNF-alpha, and it makes a big complex that's too big to fit into the receptor. It's the same effect though, same result. That cascade doesn't get turned on, you don't get production of MMPs. But we know the body's not perfect when it comes to stopping things 100%. So PRP actually has a third way for blocking some of these MMPs that did get out. And that's through the growth factor TGF-beta. TGF-beta will act directly on the nucleus to produce something called TIMPs. And this is tissue inhibitor of metalloproteases. What they do is they neutralize MMPs. So they've got another way to block the ones that come out. So with this, I hope you have a better understanding of truly how advanced they are at blocking inflammation. And the other thing is, one of the concerns with corticosteroids is it predisposes to infection by suppressing the immune system. There's no evidence of that. There's actually evidence PRP is antimicrobial against a variety of conditions. There's actually in vivo data, not in the horse, but in the dog, that it can even be antimicrobial against MRSA. Okay, last thing about the in vivo stuff is laminitis. So Jorge Carmona is a researcher in Colombia who's done a lot of really good work with both PRP and PRF. And he wrote this paper a couple of years ago on laminitis. And it's not a clinical trial or anything. Instead, he kind of does what I'm doing, which is he goes through the pathogenesis of laminitis. So here's the problems that occur in the disease. And then he goes, here's how PRP works. Just making a good argument for why PRP could be a rational choice for it. And then he gives some case examples from before and afterwards. I don't think we have enough evidence to say this should be your treatment of choice, but I do think you should seriously consider this as being another arrow in your quiver. So when you get some of those cases that aren't responding to your regular treatments, you might have something else to throw at them. Okay, let's switch over to cellular composition. So we have different types of cells that can become in PRP. Everybody wants to know the $64,000 question. All right, what's the best formula? And my response is always the same. Not so fast. I first need to know, what are you treating? Because an acute injury isn't a chronic injury. A clean wound definitely isn't a contaminated wound, and a joint isn't a tendon. So just ask yourself, do you think there's some magic formula for PRP that's going to work best for everything? Just intuitively, no. We're going to adapt our PRP based on the condition. And there's some things we know. First of all, we know that there's a lot of literature that platelet rich works better than platelet poor. But there's also data, and that's the in vitro one I showed earlier from Lisa Fortier. That was one of the ones that showed that you can actually have negative effects. So it's kind of diminishing returns when the platelet concentrations get too high. Fortunately, PRP has a really wide sweet spot. And I'm going to talk about that coming up, about the reasoning for that. There's a difference between platelet concentration and platelet dose. And that's why I think PRP can get why sometimes PRP works with 1.5x, and sometimes PRP works with 10x concentration. All right, next up, cell type, Federation sites. I am not aware of a single study that shows red cells do anything good in PRP for any condition. But there is information that red blood cells, especially in combination with white blood cells, can be bad news in joints, and I'm going to go into that in detail. In my opinion, I'll just wait until we get to that point. I think the most contentious component of PRP, though, is white blood cells. My general rule of thumb is if it's acute, I don't care the tissue. If it's hot and inflamed, it doesn't need any more white cells. If it's chronic, now I'm going to consider them. I'm going to look at what condition is it to determine if I want them. And lastly, if I'm treating something contaminated, then I'm seriously going to consider including white blood cells. All right, so these academics out of Australia did a meta-analysis wanting to know what's the best PRP. But they were smart enough to pick a specific condition, so they picked tendinopathies. They did a meta-analysis. They were able to find 18 studies that met the criteria to combine this over 1,000 patients. And what they were looking for is, what's the best data? What's the best way to use PRP for tendinitis? And they found doing a single injection and ultrasound guidance. And ironically, ultrasound guidance isn't as common on the human side as it is in the veterinary field. But here's the thing, leuko-rich. The best data says tendons should be treated with leuko-rich PRP. All right, now we get some academics from Europe who posed the same question, this time for arthritis. They found 19 studies that met their criteria. They found the best outcomes were associated with a single spin. So with PRP, you can make a single spin or double spin. The kit that we make, you can do either single or double. And I honestly can't remember last time I did double spin, because the single spin, it's easier. And I'll show you in the next slide about dosing, why you can get a lot of it, but it's also quicker. You're not spinning it twice, and time is money. And secondly, it's less chance to mess it up. But what a single spin will give you is, at most, it will give you moderate concentrations. To get those high concentrations, 8x, 10x, 12x, you have to do a two-spin system. Well, here's the best literature saying you don't need to. Not that you don't need to, you don't want to. They also said avoiding red cells, and I'm going to get into more detail like I just said. They said fresh works better, but here's the kicker, leukopoor works best. So you're going into a joint, you don't want white cells. You're going into a tendon, start thinking about white cells. So what's the difference now between platelet concentration and platelet dose? So this is a tube with blood that's been separated. If it's been separated properly, you're going to have a gradient. So this will typically be, the bottom half will be platelet rich, the top half probably not. So let's assume whole blood, we started with 100 platelets per mil. That number's not quite right, but don't worry, but it just makes the math easier. So let's assume we take 1 mil out of this so we can have relatively rich 3x PRP. We've got 1 mil of it, so 1 times 300, that means there's 300 platelets in there. Now imagine, instead of taking 1 mil, I take all of that plasma, and I put it into a tube. So now I've got 5 mils in here, but here's the thing, that platelet poor plasma still has platelets in it. And there's also a volume of plasma. So now I've got 5 mils of 1.5x, but I have 750 platelets. So you go, whoops, apologies. When you go through the literature, some of the early studies where they were using really high concentrations, those 8x, 9x, 12x, and they sometimes weren't working. And there was one paper where they looked it up and they said, you know what, when we go back and look at those studies and we look at the dose they gave them, it may have looked like a high concentration, but they actually gave them a low dose of platelets. And this is one reason why I think horse is a really good animal for PRP therapy, is because they're a big animal. They've got lots of room. We don't have a problem getting decent volumes into them. Okay, when we're injecting white cells, people will typically say, some of the companies that they're like, oh, ours are great because we have less neutrophils, which is true. And that is a good thing, because there's no such thing as an anti-inflammatory neutrophil. Whereas you can have an anti-inflammatory lymphocyte, and there's anti-inflammatory monocytes. All neutrophils are bad, but they're not the major problem when we go into the joint. It's monocytes. And this data has been known for decades. It started with research into hemophiliacs who get joint bleeds. If you ever want to see just horrible, horrible pictures, Google hemophilic arthropathies. So they've been researching and trying to figure out what is happening. And here's what's happening. When red cells get into a joint, they're going to break down because they're no longer in the circulation. And when they do, the monocytes recognize that those platelets, those red cells are deformed, and they become activated. So in the circulation, in a normal animal, most of the monocytes are kind of agnostic. They're not pro-inflammatory, they're not anti-inflammatory, they're just hanging out. In this situation, they become activated, but unfortunately in a pro-inflammatory phenotype. And they produce that bad guy we talked about, interleukin-1, and it stimulates chondrocytes. Not only does it stimulate chondrocytes to produce MMPs, like we talked about, but they can also produce hydrogen peroxide. Now, when those erythrocytes break down, they also release iron. And there's something called the Fenton reaction. That's where iron helps catabolize hydrogen peroxide into hydroxyl radicals. And if you guys remember that from chemistry, hydroxyl radicals are highly unstable molecules. They're either going to steal an electron or give an electron to another molecule. And when you do that to things like, say, cellular membranes or DNA, you can change the shape of them and they're no longer functional. They've shown that one injection, this is in vivo data in the dog, one injection can lead to lasting changes in the synovium and cartilage. And we know it's the monocyte because if they block at the monocytes, these changes don't occur. So if you are injecting a joint, your PRP should be yellow. Because if you avoid red cells, you're taking half of that battle out of it. Okay. Next, I'm going to go to FAQs. And this is questions that are frequently posed to me as somebody who works with a company with PRP kits. The first is, can I freeze? Okay. I say, let's go through the physiology. So platelets contain a variety of organelles. One of them is the alpha granule. And we focus on the alpha granule because that's what contains most of the growth factors. But there's other things in there as well. But when platelets become activated, what's going to happen is that alpha granule is going to migrate either to the endoplasmic reticulum or to the actual cell wall, and it's going to exocytose, and it's going to release its growth factors. Okay? It's called activation for a reason. It's an active process. What about freezing? Freezing is different. Ice crystals form, cells shatter, and now everything can be released, including things like fragments of cell membranes and lysosomes, which can be pro-inflammatory. And we have data from the horse. This is published at the University of Florida, where they made equine PRP and they froze it in a variety of different freezing conditions, from a regular freezer to liquid nitrogen. And they found that some of the growth factors, doesn't matter if you put it right away into liquid nitrogen, those growth factors don't hang around. But even a single freeze-thaw cycle can increase some of these matrix metalloproteases. Remember, we talked about before, these are collagenases. They break down collagen. So clearly, frozen PRP is not the same as fresh PRP. The conclusion, it can be less effective and could potentially be pro-inflammatory. Now, if you remember that paper out of Europe that talked about PRP for arthritis, the single spin, they also showed fresh works better. So to conclude, the pros for freezing is you don't want to waste it. I know if I've got leftover PRP, you're like, what? It just seems like a waste. The other thing is too, yeah, you can save some money. And last, this is one that if you have a horse that's really fractious, collecting blood can be an ordeal. So you're like, if I can freeze it, I don't have to come back and collect horse from that horse again. The cons, there's regulatory issues and the liability issues, and I'm going to talk about both of those in the regulatory section. We know PRP, when it's frozen, is not the same as fresh, and the best evidence out there shows it doesn't work. So the pros is convenience and money. The cons comes down to best medicine. So you have to make the call. Another question I have is, okay, I make a PRP, how much time before I inject it? Now, there's actually good data. This is a publication in the horse. But first, I tell people we've got two timelines when it comes to PRP. We've got time from when I draw blood until I process the PRP. And then I've got times I've got my PRP drawn up until I actually inject the horse. So that first window I want to keep as short as possible, but it doesn't have to be minutes. You could literally do it in an hour. So for most of us in our practices, you could probably get the barn, drive it in, and spin it down. I mentioned you can do PRP without an anticoagulant. Don't try that without an anticoagulant. If you're doing it without an anticoagulant, you need to spin it down right away. This is talking about following the instructions in the kits. Once you've got your PRP in this in your syringe that's ready to inject, at this point, if those platelets activate, they're not going anywhere. I've already got them trapped in the syringe. Now, if it waits too long, it might form a gel, which would suck. But if you use the right anticoagulant, that really shouldn't happen. And what we know is those growth factors, they're going to be good for 6 hours. It also says room temperature. You don't want to freeze them. You don't want to put them in the fridge. Similarly, you don't want to put them on the dash on a hot summer day. So if you're in Texas in June and you had a choice of putting it on the dashboard or in the fridge, I would wrap it in towel and put it in the fridge. Otherwise, if you're in a place with room temperature, just leave in room temperature. So imagine you're working on PRP with your technician and there's an emergency, colic, who knows what. Have your technician or you get the PRP till it's drawn up in the syringe, put it out of the way, clean spot, go deal with your emergency, come back and you can still treat it that day. Okay, next thing I get asked is, what other modalities can we use with PRP? There's not a lot of data and there's less data in the horse, but we do have some. The first thing too is when you compare PRP versus HA, well, that meta-analysis went through it. PRP works better than HA. But there's actually good data about using PRP with HA. There's so much publications on the human side that they've actually done meta-analyses. What they've shown that early on, there wasn't much benefit to HA, but the effect lasted longer. So their conclusion, PRP seems to have promising effects and no greater risk to the patient. So what I do is, if I'm working on a patient, if I'm going into a joint that's, say, a smaller volume, distal interphalangeal joint, so I'm at a pastern joint, I'm not going to be able to put 5 or 6 mils into there. I'm only going to put 2 or 3 mils into it. I'm going to use all PRP. But if I get up to a medial femoral tibial joint that can easily handle the volume, I'm going to put in 5 mils of PRP, and assuming the budget would allow it, I'll follow that up with some HA. Shockwave. Okay, there's only one study I'm aware of that tried to compare the two. It was a multi-center study, and they started with 96 horses, proximal suspensory disease in Western performance horses. Now, they did forelimbs and highlimbs, which is an argument. There was one real problem with this paper, and that was the dropout rate. 40% of the horses didn't make it to a year. So I don't think you can draw conclusions comparing the two. They did say something that I would agree with, and that's that, yeah, both of them seem to work, which is something we kind of know anyway. There is data combining, this is also data in the horse. So this is at the University of Georgia. This is Jens Stabler, neovet did this, and we actually helped him in our lab as well in Kansas with some of this work. So he has a little ballistic gel with a chamber in the middle that he fills with PRP. And then he takes the shockwave and shockwaves through the gel to focusing on the platelets. The whole thing you want to know is, would shockwave help those platelets release growth factors? So they looked at fresh PRP, which presumably most of the growth factors are trapped in the platelets, frozen PRP, where most of them have been released, versus PRP that had been subjected to shockwave. And sure enough, they found that PRP did release some growth factors. Not as much as frozen, but more than fresh. Their conclusion, shockwave may stimulate release of growth factors. And I agree. I think shockwave stimulates release of growth factors. It helps activate them. What I don't know of, does that have any clinical effect? I know I talked with Scott McClure a few years ago about this, and there's not enough data what happens with them together, but we've got a lot of data what PRP does on its own. So what my general plan is, if it's a case we want to use shockwave, we'll do our course of shockwave first. After the shockwave, and literally like seconds after I'm done shockwave, I have no problem putting a PRP in. I won't shockwave again until I've rechecked that animal, and that's usually a few weeks later. Laser. Laser is not as common in the horse. It's one of the few modalities I think is more common in small animal. There's nothing published in the horse, but there's some good data in lab animals, and I'll tell you that and how that guides my choices. So tendon injuries, what they did is either no treatment, PRP, low-level laser, or combination PRP and laser. And here's what they did is, so this is good collagen. So this is the control group, not making a lot of collagen. That's why they're a problem. The PRP group does a much better job making it. The laser groups, and they used 2 different wavelengths, did better than PRP, but the combination was the best. When we look at bad collagen, again, this group, the control group, was terrible. The PRP did a good job. Laser's not so good, but again, the combination was the best. So this study, tendons, the combination therapy seems to work best. What they didn't say, though, is they didn't say how they did the combination in the methods. This one did. So this was one with rabbits, again with a tendon injury. Very similar, but what they did is they stated they lasered them first and then injected PRP. First of all, the PRP worked, the laser worked, but the combination worked best. So now we're going to switch to arthritis. So this is a recent study that came out, again, lab animals. So they created an arthritis model, injected with PRP, but now what they did is they didn't put the laser on the animal, they put the laser on the syringe that had the PRP. So they put that energy into the syringe of PRP. So the PRP group alone improved cartilage scores, but that beneficial of PRP it wasn't seen in the irradiated group. So my general recommendations when it comes to laser is kind of like shockwave. I have no problem if somebody wants to use laser before PRP goes in, but once I put PRP in, I'm not going to laser that site again. I don't care if you laser somewhere else, but I'm not going to laser that site again until I do my recheck and see how they're doing. Okay, I'm just checking how we are for time. Okay, we're actually pretty good. So regulatory concerns. So one question I get asked is, why don't I just make my own PRP? So my response to the veterinarians is, oh, do you make your own syringes? No. Do you make your own exam gloves? No. You know those are medical devices, right? Well, guess what? PRP kits are medical devices, and they are regulated by the FDA. On the veterinary side, we are subject to the same regulations, the same controls as the human side. There's one big difference, though. On the human side, you need permission to sell it. So you have to jump through all the regulatory hurdles. I know we're on the human side as well. You have to jump through all the regulatory controls before you're allowed to sell it. On the veterinary side, it's more a system of forgiveness. So this is kind of why it's a bit of the Wild West out there with medical devices, because these companies are willing, some of them, actually not all of them for sure, some of them are willing to take a chance that, if I mess up, I'll just get a slap on the wrist. I'm personally risk averse. The other thing I've said people, so first of all, they're medical devices. So one thing to make a medical device is you have to be registered with the FDA as a manufacturer of medical devices. Second thing is you have to do CGMP, and most people are like, well, what is CGMP? Well, the picture, that's me in our factory that makes medical devices. That's what a CGM factory looks like. You've probably driven past factories and you see a banner that says, we are ISO 9001. What those ISOs are, it's a quality management system. The 9001 is a generic one. So from sports teams to doctors' offices can do 9001. And what it basically does is it makes a company more efficient. They've shown that companies that are ISO certified make more money than companies that aren't. Well, ISO 1345 is an ISO specifically for medical devices. And it is a ridiculously prolonged process to go to. And it's 90% of actually what you have to do to get through the FDA approval process. This brings up the liability. Remember before I talked about liability concerns? So imagine you made your own PRP, you injected a horse, and the horse had a reaction. And we all know it doesn't necessarily mean you did something wrong per se. Sometimes stuff just goes sideways in vet med. But now imagine you're on the witness stand and the lawyer gets there and he says, okay, are you CGMP? No. Are you USI? No. Are you federally FDA registered? No. Okay. So you decide to save $90 when treating my client's $80,000 horse, correct? Yeah. Did you tell my client that there were kits made out there that met all these criteria? Yeah, you can't see where this is going. Liability insurance does a great job at defending veterinarians. They will go to the wall for us if we meet the standard of care. If you're making your own medical devices, you are not meeting the standard of care. Other thing to look for is, and this is something equine vets especially are very familiar with, is extra label use. Every PRP kit on the market in the US has this exciting label: mix with bone to improve handling. Shake the pom-poms. Seriously, that's the only labeled use. So that means everything else we're doing is extra label use. When it comes to extra label use, though, first of all, extra label use is actually in the federal code of regulations. That's the federal law that is protected. But they have some guidelines to help us. The first thing is that it should be medically appropriate for the patient. So because my client asked for it, that doesn't make it medically appropriate. Other things that can really help you is, and this is what happens a lot in vet med, is there are no approved treatments for that condition. Okay, that makes it easier. We have to use something that's not approved. That's off-label. Or it may have approved conditions, but they're not responding. One thing, those are not conditions, so those are just things that can help you make the decision. You do need to have a balanced relationship, vet-client-patient relationship. Now, unlike a prescription where somebody's just picking it up, this, you have to get hands on the patient. So there's going to be some relationship, but if somebody asks you to do PRP, at a minimum, I would do a physical exam and record what that was. At least that way you establish that you're treating a specific condition. Here's an interesting thing too. You can turn PRP into a drug. And when I say you, I mean you, the veterinarian can. I had a talk with Lynn Boxer. I don't know if anybody knows Lynn Boxer. This is at the regenerative medicine meeting a couple of years ago in Niagara Falls. We were talking about regulatory concerns. And imagine I got horse A in front of me. I draw blood from horse A, I go to my kit, I make a PRP, and then I go and I inject horse B. I use it in an allogeneic manner. I have just created a drug as the veterinarian. When it comes to cells and tissues, the FDA has certain standards that makes them go from a device to a drug. One of those checklists is allogeneic. The other one is a separate procedure. So remember we talked about freezing and why you probably shouldn't? The FDA, they talk about minimal manipulation and being part of the same procedure. So if you take PRP out of a horse, freeze some of it, and come back to another day and treat them, that is a separate procedure. You technically have made a drug doing that. The last is claims. So the only labeled claim is mixing with bone to improve handling. Now, that doesn't mean you can't talk about it. Here's an example. This is from the Mayo Clinic. I'm not endorsing the Mayo Clinic at all. You could find a whole bunch of major medical centers that talk about PRP. But you notice they don't use the word treat, and they don't talk about any expectations. It's more, hey, we offer this. Okay. Also, on the topic of the Mayo Clinic, so this is from the chair of the orthopedic department, kind of what the FDA guidance said is make sure that your plan is supported by the evidence, but mostly evidence of safety. Be convinced that what you're doing is safe. Efficacy, that's the one where you've got a little bit more flexibility. And the last thing he says is don't rely solely on the information from the manufacturer. And so what I'm saying is don't necessarily listen to me. I try to be objective. I hope that comes across. But I'm one person who clearly, I work for a company, so you have to take what I'm saying with a grain of salt. All right, this is a recent study, came out literally just a month ago, where they took athletes who had tendon injuries and they randomly split them up into PRP or saline. Then they collected blood and urine to look for various biomarkers to say, hey, can we test if somebody's gotten PRP? There was only one thing they found that was different, and that was the PRP group had less serum substance P. A couple things. We truly don't even know everything about serum substance P. For sure, increased levels are associated with a lot of diseases. And in some diseases like traumatic brain injury, high levels are indicative of mortality. They did find is when they looked at anabolic molecules or anabolic metabolites, they couldn't find anything. So their conclusion is we don't see that you can test. So yes, you can find reduced serum substance P, but we don't know that that's necessarily caused from PRP. Now, as Dr. Tobin went over, testing methodologies are getting better and better. So maybe they will be able to come up with, okay, this profile is indicative of PRP. I don't know if anybody saw this paper, came out, I think about a year and a half ago, out of New Bolton Center, where it's actually quite well done study. They took blood before shockwave, and then they gave them shockwave, and then they took blood afterwards. And they found several growth factors and cytokines had different profiles in the horses after they were shockwaved, out to 20 days, I believe. Now, again, those growth factors can change for other reasons. So we don't have a test yet to say, oh, that horse got shockwaved. But I wouldn't be surprised if in the future they were able to say, okay, this profile of these growth factors and cytokines is indicative that they've had shockwave. And already they said they could test it out 20 days after treatment. Okay, lastly, and then we can get into some questions and we'll go over our system a little bit. I'm sure a lot of you saw this in the Blood Horse today, talking about the indictments that are ongoing. And in the article, they said that growth factors are not approved to give to horses. And that was kind of a broad categorization. So we've reached out to some regulatory people, and thank you, Dr. Palmer, for getting back to me today. He says that's actually not quite true. PRP and IRAP treatments are permitted to be used. This is New York State under the following conditions. Has to be prescribed by a vet and must be reported if sampled. We also talked to Dr. Howard yesterday, even before this article came out, and he can't be with us, but fortunately he gave us a quote that we could use. And that's that in Kentucky, PRP and IRAP can be used for procedures if they're reported. If there's intra-articular, there's a 72-hour stand-down time, assuming corticosteroids weren't used with it. Further, if it's being sampled for out-of-competition testing, it should also be reported to the regulatory veterinarian at that time. Okay, so take home. there's a huge body of literature supporting both the safety and efficacy of PRP for a variety of conditions. When it comes to joint, the best data out there says you don't want white cells and you don't want red cells. When it comes to tendons, I seriously think you should start including white blood cells. The caveat would be if it's that acute one. If it's an acute tendon injury, I still err on the side of the fence of I'm more than likely to exclude them. PRP kits are regulated medical devices. Most of the uses we do are considered extra label. And lastly, I just showed you what New York and Kentucky said, but that doesn't mean it's the same in Florida or Ontario or California. Check with your local racing commission. And with that, we've got plenty of time to go over some questions. I know Mary Lou has got the chat function. While we're getting those sorted, if you want to think of questions, here's my cell phone, here's my email address. If you ever have something that's urgent, feel free to call my cell phone. If I can't answer, send me a text, because a lot of times I can't talk, but I can usually text. Otherwise, if it's not urgent, just send me an email. I'm going to, while the questions are coming and getting piled, I'm just going to briefly talk about our system. So our PRP system is called Rebound. And yes, it is CGMP. Yes, it is ISO. Everything we do, we're based in Manhattan, Kansas, and everything we do, it gets validated through Kansas State University. When I was designing this system, and first of all, this is version 4 on the market. Version 1, version 2 never went on the market. We spent years developing them. We had version 3 on the market for maybe a few months, and then we had feedback from vets, so we made version 4, and that's been on the market now for a while. But the first kind of criteria I had for the system was I didn't want vets to have to buy a new centrifuge. So we designed a tube the exact same dimensions as a 10 mil vacutainer. So the vast majority of vets out there, if you've got an adjustable centrifuge, chances are it's going to work, so you don't have to buy one. But if you do need one, we have one that's portable. So this padded carrying case is holding a centrifuge and 2 PRP kits. So you can always be ready to go. As far as I know, we're the only one that came to the vet market first. So we're not buying it from the human side and then turn around and selling it. So we don't have that middleman. So our kits we can retail for under $100. That gives you 2 syringes of PRP. We have the only system that I'm aware of that can make both leukorich and leukopoor even within the same kit. So how are we doing it? So person who really helped me out was Dr. Charan Ganta. He's a board certified veterinary pathologist, but also a regenerative medicine expert. He was at Kansas State University. He's now moved on to the NIH. And we decided to make our own PRP kit. And we said, okay, what's the minimum we need to start with? And we said, it's a tube and a needle. So we got a spinal, we got a tube. And we found we kept getting contamination, red cells and white cells. The only way to avoid it was we had to stop the needle pretty high up, which meant we were leaving a bunch of good PRP in the tube. So pulled out a magnifying glass, trying to figure out what the heck was going on. And we realized because that needle's pointing down, it aspirates vertically. So it was literally sucking white cells off of the buffy coat. So fortunately, I got introduced to this guy. Well, not this guy, but his invention, the Whitaker spinal needle. So it has a tip like a T cannula on the side. So it aspirates horizontally. So it doesn't suck off white cells or red cells. The only way you get them is if the tip of the needle disturbs the buffy coat. And you'll know that because your PRP will change color instantly. So we've given the user control for making PRP. We have an instructional video. So when you open the kit, there's a QR code. We're also now starting to add the QR code to the outside of the box. It takes you right to our webpage where you can see the instructional video. I'm not going to show you the instructional just for sake of time, but I'm going to go through some stills from it. So when you open the kit, you notice it stops, right? Ours is the only kit in the world that opens in stages. So while you're collecting blood, and a lot of times, we're working in a barn. There's a groom sweeping, there's horses walking by. So while you're doing this, everything else in the kit is protected. We also include all the syringes, all the needles, and the anticoagulant. We color coded it. Whole blood is red, so you inject it to the red side. Plasma is yellow, so you have the yellow port. We know centrifuges are the weak link when it comes to sterility in PRP, so we protect it with a sterility sticker. The other thing is we designed our tray to actually be a workstation. So no matter where you are, because a lot of times you're working in a barn, at least you can create a little sterile work field. The other thing is PRP, when it's separated, the reason you don't want the brake on is you don't want to disturb those red cells. Because if you do disturb the red cells, if that tube fell over and disturbed the red cells, you'll never get your platelet concentration back. So we built holders in the tray to keep them vertical. But you can make 2 syringes of PRP. So you can make 2 liquid depleted, or you can make 2 leukorich, or you can make one of each. All right, and with that, let's see the chat if there's some questions.
So Dr. Orava, can you hear me?
Yes.
Okay.
Yes.
One question that I'm seeing here is, when do you recommend, like, has there been any conversation on of when to give PRP for horses in training versus horses that are racing? Is that something that should be done post-race? What do you recommend?
Yeah, I'm definitely much more inclined to give it post-race than pre-race. And this is one of the reasons, and I talked with Dr. Palmer today, was one of the reasons why PRP isn't banned is there's no evidence it's performing enhancing. So it's not going to make you improve anything you can do. It can just make you, help you hopefully repair if something is wrong. So the other thing is it's a slower onset, the lumbar facet study I covered. So you don't get that potent kick of corticosteroids. So doing it right before a race. So I think typical interview is typically about a month between races. I think that's a perfect interval for PRP. So after a race, that's when I'd be inclined to give them PRP.
There's another question.
This website right now, while you're saying it, this website is actually kind of like a one-stop page on our website if you want more information. I'll just leave that up there for now. Yep, go ahead.
Okay, so recently there was an article too about kissing spines. Can you comment on that?
Yeah, kissing spines is sometimes the diagnosis du jour, depending on what circle you're in. We definitely see it, and I'm convinced it is a definite disease, but I think there's a lot of gray zone in there. There's no evidence, no published evidence of using PRP for kissing spines. But having said that, I wouldn't be opposed to injecting PRP. I've never done it, but I wouldn't be opposed to trying it. There's sometimes where they definitely need surgery, and I think that's where I would strongly talk to the surgeon and say, hey, here's the evidence. Why don't we use it in conjunction with surgery so hopefully we have better healing? But there's nothing published. That's just my opinion. Okay,
we have another question here that this veterinarian was trained that PRP could be problematic to injection in joints, that it's fabulous in tendon injuries, but to be avoided in joints as flares are more common. However, the research you've presented says otherwise. Can you clarify?
Yeah, there's definite dogma around joint flares with PRP. There is a study showing, this is in the human world, it was out of Japan not too long ago, where they made leuco-rich PRP and leuco-depleted PRP and showed that the leuco-rich were much more likely to have not necessarily a defined flare, but significant pain after injection than the leuco-poor. So the literature for arthritis in humans is overwhelming. There was a recent regenerative medicine symposium. Mark Ravana, Dr. Mark Ravana, a vet up in the Pacific Northwest, hosted it. And Lisa Fortier was one of the guest speakers. And she really said, like, this evidence for PRP in joints is about as strong as evidence gets. We have way more evidence for PRP for joints than we do for tendons and ligaments. And I think there's some vets who use it for one, some vets use it for other, but more and more that's using it for both.
Okay, and we have a question for Dr. Tobin. Dr. Tobin, you may be on mute, by the way. If the question for you is, I routinely collect serum and freeze during pre-purchase exams. Does that affect the half-lives of possible medications for testing weeks after purchase? Is there a better option? Excuse me, it's changing before I can read it all. Is there a better option in case of temperament, lameness, changes post-purchase? Is Dr. Tobin still on? Oh, there he is.
Yeah, I'm unmuted.
There he is. Okay,
yeah.
There
you go.
Can I hear the question again? Forgive me. Can I hear the question again?
Yes, sir. So it says, I routinely collect serum and freeze during pre-purchase exams. Does that affect the half-lives of possible medications for testing weeks after purchase? Is there a better option in case of temperament, lameness changes post-purchase?
You got two questions there. If you freeze the sample, you should stabilize the substance in the sample. And as long as you hold it frozen, and particularly if you hold it at minus 20, that should stabilize it, and it will the substance will be retained. Now, the second question, I haven't quite gotten my arms around it.
Is there a better option versus freezing?
For what?
I guess it's better option for freezing in case of temperament/lameness changes post-purchase. So I'm wondering if it's freeze.
What she's saying is, if the sample is going to be analyzed a number of weeks or months after the examination, I would be, to my knowledge, no. Hold the sample frozen. Yeah.
Okay, thank you.
I'm just going to add something into there, because in that study at Florida where they were measuring frozen PRP, a standard household freezer is a -20 freezer, but they actually tested two different types of -20 freezers. The old-fashioned one where the frost would build up and drive you crazy, or the new ones which are frost-free. And the frost-free freezers, actually, the reason they are frost-free is they go through a cycle where they warm up to about -6. So they're not consistently at -20. So I'm not sure, Dr. Tobin, if that could affect the storage of some of these samples.
I would be more comfortable with a 24-hour -20 rather than the warm up.
Okay, yeah. So that's why in our laboratory we have an old-fashioned freezer that collects frost just for that reason, because some of our lab samples, just to maintain them.
Yeah.
Okay, Dr. Orava, what do you recommend for standardbreds who race every week?
Do I think every horse needs that's racing? No, they don't. You use your clinical judgment and see how they're doing. And every horse is going to respond slightly differently. Obviously, you've got to look at the budget too. So when you have time, treat them. See how long the response lasts. Would I treat them every week? Like let's say it was a hawk or a carpus. Would I treat them every week? I don't think. I think that's unnecessary. I think that's overkill. I might be proven wrong, but I just think that's overkill. I'd be more likely inclined to say, let's give them a treatment and see how long it can last. I'd be surprised. Now, ideally, I'd rather do it when there's kind of downtime, so the body has time to hopefully heal. And they don't need 6 months off, but maybe 6 weeks off. I think they would likely have better long-term outcomes than if you injected it and they only had a week off. Hope that answers that. I put up the data from our kit. This is numbers, and I apologize. I didn't realize I had the canine data, but I have canine data and human data. The equine data is actually pretty darn close to the canine data. I know the platelet dose is a little under 6 billion and the yield is a little under 80%. Otherwise, they're almost identical.
Okay, we have some more questions. So, Dr. Orava, when in relation to acute tendon injuries or acute suspensory ligaments, would you recommend injecting?
Yeah, so that's like what I do is I rest them. In my world, I can give them NSAIDs without concerns because they're not going to be in the FEI ring if they've got that type of injury for a while. So I'm going to give them an NSAID. I'm going to ice it. I'm going to wrap it, and I'm going to rest the horse. And then I'm going to come back and check them typically in about a week, unless something untoward happens. So I'll look at them, say, 5 to 10 days later. And if that leg, if there's no heat and minimal pain on palpation, that's when I'd consider treating.
Do you ever recommend mixing PRP with steroids, hyaluronic acid, et cetera?
Yeah, so I addressed the hyaluronic acid, but to summarize, if I'm in a large enough joint that can handle the volume and it fits the patient's budget, then I won't just do HA. I will recommend combining HA with PRP.
This says also to drug testing for post-purchase, to clarify that question.
Okay, and so I don't know about HA and testing. That's not my wheelhouse. Just like my wheelhouse is PRP, I can't comment on HA when it comes to testing. I'm just coming from a point of view of efficacy. When it comes to efficacy, I believe in mixing HA with PRP if the budget allows it and you're in a joint where you've got decent volume to work with. When it comes to steroids, I know some people, I talked with one a couple months ago, a referral hospital where they mix PRP with steroids. And I'm like, okay, there's nothing in the literature to support that. I do not recommend doing it. If you're doing it, okay, you're on your own. All right.
Okay, and we have a couple more for you, Dr. Tobin. So this one is, to what extent are isomers or stereoisomers problematic in drug testing, and can they have different physiological effects?
The answer is yes. They can have different pharmacological effects. The way the chemists get around that is they say that even though the isomers are different, that if we detect them, we don't have to bother about the isomers. So you're in trouble quite independently of which isomer is detected. Therapeutics has moved towards more specific isomers, which is an advance. Most drugs are that are available are racemic that consist of both isomers. Does that answer the question?
I believe so. And Dr. Tobin, how are you stabilizing serum for frozen storage?
For me, I would just routinely simply freeze it. If you've separated the serum out, put it in a small plastic tube and just freeze it. It doesn't need any particular stabilizer that I'm aware of.
And Dr. Orava, do you ever shockwave post PRP injection or always before?
I don't always before. First of all, I don't always before. But there's some indications where it's indicated and the budget will allow it, then we will do it before. Afterwards, I always wait until I do my recheck. So it's typically going to be a 2 to 4 weeks afterwards where I'm doing my recheck, where I'm going to see the horse, palpate him. Hope if it's a tender ligament, I'm going to ultrasound him again. And at that point, if they haven't responded the way I expected them to respond, then I would consider doing another shockwave treatment, or I would consider doing another PRP treatment as well.
How much are you generally injecting into fetlocks or carpal joints?
Well, it's going to depend on the size of the animal, but fetlocks and carpal joints probably in that 3 to 5 mil range. You don't want to force it in. Actually, this is a really good point because somebody brought it up. So if I put a needle in and there's fluid coming out, I always love getting fluid because that way, first of all, you're 100% you know you're in the joint. And 2, it gives you some evidence of what the health of that joint was. If it drips like water or squirts you in the eye, it tells you that fluid isn't doing any good in there and you want to get it out. So I will try to aspirate fluid out of the joint, in which case I can now put more in. So that 3 to 5 mil, that's in a horse where you might get a little flashback or you don't get any fluid back. There's also some evidence too that in those, this is human data, if you can get that PRP, some of that synovial fluid out and PRP in, they actually will do better. So, but just general guidelines. Obviously, smaller horses, less. But what I won't do is don't force it into the joint because anything that can distend the joint can cause pain.
And do you ever add antibiotics like amikacin to the PRP injection?
Okay. Great question. For routine treatments, I do not mix antibiotics with it. I personally have been injected with PRP several times. Never have they mixed it with an antibiotic. I said the data for PRP is that it actually can be antimicrobial. There's actually a lot of data showing the antimicrobial properties of these platelet concentrate. And actually, Lauren Schnabel's lab at NC State published some good papers recently. It was more platelet lysate, but same general idea, showing that we know one of the problems is with infections is the development of biofilms. And the problem with biofilms is it creates a layer that antibiotics typically can't penetrate. They showed that the combination therapy, and I'm pretty sure it was amikacin, but don't quote me on it, but the combination therapy of the antibiotic with the platelet lysate actually works best for them. Now, so if I had a septic joint and I was going to treat them, I would do and assuming it wasn't one that didn't go for surgical referral, we would lavage the joint and then chase it. And that's where I would add the combination. I would probably do amikacin and PRP into it. But for routine joint injection or routine tendon ligament injection, I personally don't use amikacin. There's nothing in the literature to say it's wrong. It's going to do any harm. So if you want a CYA, if you're going to sleep better, I'd have no problem doing it. I simply don't.